I can't. Have you?
Yeah, we can hear you, but start your video, doctor.
Yeah.
Yes, doctor.
I thank everybody for their patient listening, and I watched all the questions coming in. I have requested Dr. Daniel and Dr. Patrick, who are really on service today, to wait for some time. So all those who have questions to Dr. Patrick and Dr. Daniel, please ask now. We will still have with us Dr. Banaclari and Dr. Vineet, who will answer questions as they come. So I request the audience to ask your questions to Dr. Daniel and Dr. Patrick in the beginning, so that they can get back to their service. Thank you.
I have a question for Dr. Daniel, please.
Yes, I cannot, my camera is not working. Apparently, I'm not allowed to use my camera, but, oh yeah, okay, great. Can you hear me?
Yes.
First of all,
Okay,
this is Dr. Vidyasagar.
go ahead.
First of all, congratulations for a very excellent presentation by you and the various, all the panel speakers. My question is, you and Dr. Bhandari may answer, if there is a data regarding the cord blood levels of vitamin A and BPD. And second question is, if vitamin, it seems to me among the many therapeutic interventions, vitamin A seems to be very benign. And also, so far your data shows that you need to treat only 14 patients to prevent one BPD. Nevertheless, vitamin A is much more easily available, easily administrable, and why not we really recommend that as a use of vitamin A in all these high-risk patients, babies? That's my question to you and the panel.
So I can answer that question, and then I don't know if Eduardo will be there too. So vitamin A, as you mentioned, it is a fairly benign drug. You have to give IM injection actually based on the original John Tyson's trial 3 times a week for at least 4 weeks. Now, again, you heard Daniel giving a different protocol. Oral vitamin A has been shown by multiple studies done by Ambalwanan, for example, from UAB, that at least the dosing regimen that he used did not seem to be beneficial, but we have to wait for some of the new studies that are working. What I believe, and Dr. Shania, Jayant Shania had written a very nice article on this many, many years ago. The issue is that if you already are if your levels of vitamin A are above a certain level in the neonatal levels, then giving extra vitamin A does not seem to be beneficial. So you are over treating. It's like if you give surfactant to all babies less than 28, you will be over treating, giving surfactant to at least 30–40% babies who do not require it at all. So that is the same concept that I'm trying to say. If you have a population, and if you have a population of babies where the maternal vitamin A is low, or you could check it by cord blood levels, if they are low, and Daniel mentioned a level of less than 0.35 microliter, I think, that was there. And if you use that kind of a cutoff and then selectively treat, then I think potentially you will have more benefit. As I mentioned in my talk, if you really look at the data from John Tyson's study, there were a lot of babies who were from Texas, Alabama, Mississippi, the southern part of the USA at that time. And that place is, and there are separate studies that have shown that those areas have maternal undernutrition and low levels of vitamin A. So the benefit that was seen there was probably because of that, because if you remove that population there, the contribution of the babies of southern USA compared to the northeast and Midwest, you may not have seen that benefit. So I think selective or targeted vitamin A in a particular population where there is low levels of vitamin A in the population would be helpful, I think. But then if your levels are okay or normal, then you're just giving IM injections and you're not going to see any benefit.
But I'm talking about a very selective patients who are at risk, and we are not giving a universal treatment. But if we are taking a babies who are less than 24, 25, 28-week gestation who are at risk, so what is the risk of those babies? Do you have any cord levels correlation with the BPD?
I'm not aware of studies where they have actually looked at cord levels and then selectively decided on treatment. But I think in concept, your suggestion is fine. Maybe Daniel can expand, because they are using vitamin A, and I don't know if he has information about the vitamin A levels in their population.
Well, there may be some. I don't have any particular data about that. But then it's also true that I don't actually know how much cord level can be really, reliable in this regard, since later when you start a TPN, you start, feeding and so on, and you may have different requirements from different babies according to gestational age, according to the alveolar situation, and so on. Maybe it would be better to say blood level of vitamin A in the first 3 days of life or something like that. I don't know. That's a good question. It's a matter of discussion. Regarding the schedule, you're right, Vinet. Majority of studies were, well, the studies that have been meta-analyzed were on 3 shots per week, 5,000 units per each shot. We decided to do 15 in just 1 shot because there was an additional study comparing the 2 administration, which actually seemed to show that there was no difference. And the total dose was the thing that influenced the outcome more. Then there is one thing I want to highlight, because somebody said that it's a number needed to treat of 14. Again, this actually depends on the type of BPD you have. It actually depends on the incidence of BPD in your population. That's mathematics. You see the paper of Barbara Schmidt recently published in Journal of Pediatrics. The number needed to treat can be lower or can be higher according to the outcome incidence.
Can I say something? Dr. Patrick wanted to go early, so a couple of questions for him because he's attending and he has message to leave early. So there's one question about BPD related pulmonary hypertension. Do you have separate criteria to diagnose that, Patrick?
So that's a great question. So let me try to kind of talk a little bit in more detail. I think one of the most fundamental problems we have in contemporary care of this patient population is that our starting point is babies get BPD, then they get pulmonary vascular disease, then they get pulmonary hypertension. That may not be correct. I think it's important to recognize that, what may lead to dysregulation of pulmonary vascular bed and what may lead to kind of impaired alveologenesis and so forth may have different pathways and may be presenting at different time points. And this becomes very, very relevant for the infants at the most extremes of prematurity. Our traditional thinking is we make a diagnosis of BPD at 36 weeks and then we screen for pulmonary hypertension. And reality is that there are many babies that have early pulmonary vascular disease, early pulmonary hypertension, that may not necessarily keep pace with what we would traditionally think of as BPD. So I think, number one, there's the assessment of pulmonary hypertension, but number two, there's the radar at which point that we think about it. So we don't start our screening for pulmonary hypertension at 36 weeks. We actually started in babies either 36 weeks or 8 weeks postnatal age, whichever comes earlier. So, and if you think about it, infants that are 22 or 23 weeks, you're forcing them to wait 14 weeks to have their first evaluation for chronic pulmonary hypertension when they're probably the patients at the highest risk. So, so there's the optimal time of screening. And then the second part of it that becomes incredibly relevant is that a lot of the tools that people use to evaluate chronic pulmonary hypertension are based on subjective assessment. Does the right heart look dilation? Does the septum look flat? Is there some evidence of RV dysfunction? And kind of we know from kind of reliability studies that kind of the kappa coefficient for these things can be incredibly low. So point number one, I think we need to screen earlier. Point number two, I think when we screen, we need to look more comprehensively at, there are other additional measurements that you can use to quantify pulmonary vascular resistance, assess RV function, and so forth. And then the third part is, and I think I alluded to this earlier on, is that not all BPD or BPD-associated pulmonary hypertension is related to pulmonary vascular resistance. Screening out infants that have systemic hypertension with pulmonary venous hypertension, who potentially need a very, very different approach to treatment is one thing. And then secondly, infants that may have shunt physiology, as we talked about earlier, in particular the ASD phenotype, may also present in a BPD looking pattern. So I think, you know, if you think about it, you know, and I'm making this intentionally sound complicated because neonatal cardiovascular physiology is not simple. And I think the days of saying BPD equals you're dependent on oxygen or you're dependent on mechanical ventilation at 36 weeks is probably too simplistic. And we need to look within that patient population at what are the specific phenotypes. Is it isolated lung phenotype, lung plus pulmonary hypertension, or lung plus systemic hypertension? And then try to strategize how can you modulate each of these entities in their own unique sense. So those are my thoughts.
The same baby could fluctuate between these as well.
Oh, well, the same baby may fluctuate, but for example, you know, if you make a diagnosis of pulmonary hypertension and start the patient on nitric oxide, but the patient actually has got systemic hypertension with pulmonary venous disease with LV diastolic function, nitric oxide is not going to help that patient. You're going to make that patient worse. So, and I think this is where trials of prophylactic use as a chronic therapy have failed because they have not differentiated the patient populations. And I think, you know, if we ever get back to looking at trials of low dose nitric oxide, I think it's going to be very important to try to tease out truly the sub-patient population that have true pulmonary vascular disease with BPD.
Thank you. I mean, extending the same question, there is a question on sildenafil use. So I suppose the same answer applies that you have to choose the patient correctly.
Yeah, and again, we use sildenafil, and again, our selection of pulmonary vasodilators is normally done after, obviously, one, you want to do whatever you can to optimize the lung, make sure you're ventilating the patient well, and make sure you're taking good care of nutrition. And if you truly have pulmonary hypertension, obviously, you know, the approach to therapy really is going to depend on, you know, what are the ambient features. So we would typically use things like inhaled epoprostenol, we may use sildenafil or low-dose nitric oxide for certain patients. Or in other patients, if there's a lot of systemic hypertension, we may think about bosentan as the provide therapy for those patients. So yeah, so kind of very much individual approach based on what is the physiology, and then reevaluation, and again, not forgetting that there's a small patient population that may masquerade as BPD pulmonary hypertension, but they have pulmonary vein stenosis. And I think having a radar for that, screening for that, and if the clinical course is not going as planned, thinking about the role of cardiac catheterization.
Thank you. Just one final question.
One more question for Dr. Patrick.
Yeah.
I have also two questions for Dr. Patrick. Go ahead, Monica, you go ahead first.
Okay. It is by Pooja. She's saying like 24, 26, 28 week with moderate PDA, and baby is on conservative management, given unable to extubate at 2 weeks, and you gave Tylenol twice. When to close now the PDA, and as longer duration of PDA flow, increased BPD risk, you said, leading to PPHN. So
okay, so again, it's I think everything is in duration of exposure. I think, you know, again, going back to one adjudication of that the problem is truly a problem, that this is a pathological left to right shunt, and this is not, say, lung disease with pulmonary hypertension, I think is the first thing to do. And assuming that, yes, you are managing a high volume PDA shunt, obviously our approach, as mentioned, you know, we do a targeted approach in the first few days of life. And if by day 7 the shunt is a problem, then we will use indomethacin. Obviously, other places may choose to use oral ibuprofen, which seems to be effective in inducing PDA closure. But one of the things that really there's not a lot of literature on, and Vinny talked a little bit about numbers of courses of therapy. I think one of the things that I think, again, with comprehensive evaluation and looking more detail at markers of shunt significance helps you differentiate, did that course of therapy do anything? Because, you know, if you've given a course of whether it's indomethacin or Tylenol or whatever, and biologically the ductus remains open and none of the physiologic markers have changed, it's very hard to justify based on logic why you would give the same therapy again if it's not worked the first time, and you truly think that the shunt is a problem. Then obviously one potentially would proceed towards some form of intervention. So most of our patients end up getting device closure somewhere around 2 to 3 weeks. We have not proceeded earlier than that. There is a trial currently under planning called the pivotal trial, which is looking at percutaneous device closure between day 7 to day 14 versus a conservative arm. So that may provide additional information. So bottom line for deciding about surgical ligation, number one, do you have a problem? Is the shunt a problem? And I think, you know, if it is, I think you can proceed to some form of interventional closure. I think, like has been mentioned by other speakers, the experience with device closure is much more positive than surgical closure, but it's not completely benign. Some of these babies may still get post-closure respiratory instability from high left ventricular pressures, and then you may have kind of device complications that can occur as well.
Okay. Patrick, I have two questions. One is regarding the prophylactic use of any medicine for closure of PDA. And the other thing is that one of the participants asked about that you said in your talk that Tylenol act by vasoconstriction, okay, and it can cause pulmonary hypertension. So it is contradicting in a way that it can cause the pulmonary hypertension. So
okay, that's a great question. So again, I think it's important to, so let me take the second one first. We'll talk about Tylenol. So remember, so the effect that we know on potentially the mechanism is through some pulmonary vasoconstriction. Now, remember, pressure is the composite of flow multiplied by resistance. So although you may get some pulmonary vasoconstriction, by actually decreasing the ductal shunt, you're decreasing the magnitude of flow to the lung, so your pressure doesn't necessarily rise. Now, if you have a patient that has confirmed pulmonary hypertension on echo, you should not be closing the duct. Okay, so that's the first thing. But certainly our experience with IV Tylenol in the first 48 hours of life, we have never had to stop it because of a pulmonary hypertensive crisis. And the same logic applies with nitric oxide. And a lot of people are misguided that nitric oxide decreases pressure. Nitric oxide decreases resistance, okay? Yes. And by decreasing resistance, flow will improve. So acutely, when you look at babies, nitric oxide responders, and you echo them 1 to 2 hours later, they still have pulmonary hypertension, okay? But their improvement in oxygenation is as a result of an improvement in flow as your resistance falls. So I think the answer to the question about Tylenol is exactly the same as with indomethacin. Make sure you're not closing the duct in someone with pulmonary hypertension. Sure. If the patient does not have pulmonary hypertension, it will be well tolerated. And certainly we've had very, very positive experience with it.
There's one more question for Patrick before he goes, that you recommend early PDA closure based on scoring criteria. Is it a medicine or the surgical ligation? Is there any difference between the two in terms of short-term or the long-term outcome?
Okay, so again, the selection criteria is the identification of shunts that are problematic, progressive, based on comprehensive assessment, not just on the basis of size. So we select out these babies that already have major signs of altered QPQS. Medical therapy, so we use Tylenol. I would not recommend any form of interventional closure in the first week of life, particularly because the changes in loading conditions, obviously one, the preterm myocardium doesn't tolerate kind of major changes in loading conditions, but certainly the last, and it's a long time ago since I've seen this, but I remember in Toronto, there was, when I arrived there were a couple of babies that had PD ligation in the first 3 days of life. Both developed severe post-closure intraventricular hemorrhage. So I would not surgically close the duct in the first 3 days.
Okay. Can I ask one more question to Patrick?
Yeah, sure.
Yeah, sure. Just one quick one. What is the range for low dose nitric oxide? Is there a range, or you give a specific number?
Okay, so again, this is not based on, I don't have a randomized trial or a big study to quote, but again, you go back and you look at the trials of low dose prophylactic nitric oxide or any form of nitric oxide given chronically. The selection of babies that may have, say, PDA physiology or maybe even heart dysfunction, LV dysfunction, or particularly LV diastolic dysfunction, was not precise. So echo was not used to identify patients based on risk profile. What we do is, if we identify and confirm in a baby with severe BPD, and again, these mostly are 22, 23 weekers. I fully agree. Bigger babies, you get them extubated. 22, 23 weekers, you extubate them early at your peril. They typically end up being re-intubated quickly after being exposed to a lot of kind of high oxygen requirements. So those babies, again, assuming we've managed the ductus, we're managing everything else well. If there are signs of early pulmonary hypertension or pulmonary vascular disease, I may use low dose nitric oxide 5 parts per million for 2 weeks as a steroid-like of therapy. And we've had some real good success with that in getting babies extubated. But again, this is not a randomized trial. This is a specific practice that we use based on physiology and close monitoring.
Thank you.
Okay, so can we move to Dr. Ben-Kalari, or because I have a lot of questions for him. Is okay, Rajiv?
Okay with me.
Yeah.
Yes. Okay, Dr. Ben-Kalari, welcome back. So there are a couple of questions about the definition, the physiological and the clinical definition of the BPD, because there are old study in 2014 where Dr. Walsh said that if you look at the clinical, it shows higher as compared to the physiological. So can you kindly comment on that?
Yeah, so one of the limitations of most definitions of BPD is that we are using oxygen, that is the therapy for hypoxemia in this case, to define the disease. So that's the first problem. The second problem is that until a few years ago, before Barbara Walsh described the physiologic definition, different units had different ways of giving oxygen. Some units were keeping babies with saturations of 80, 85. Others wanted to have the babies with saturations over 95. So obviously that contaminated the definition tremendously. And there were huge differences from one institution to the other, not because the babies were different, but because people were using oxygen with different criteria. Now, today, I think most of us are using a pretty strict range for oxygenation. Okay, VNIT may use 88 as the lower range, we use 90, that doesn't make any big difference. And the high end, that is where really most of the mistakes were done, nobody uses at this point more than 94, 95%. So I think today, most units in the world are doing physiologic administration of oxygen to all babies. So at this point, if you see all the data from the NIH network, the latest data, there is no difference between physiologic and clinical definition, because essentially all units are giving oxygen based on an oxygen target that is very similar.
Okay.
So I don't think we have to worry about that today.
Sure. Thank you. The other question about, this is the era of calculators. Do you have a comment on the BPD calculator? It is validated or not?
This is for prediction of BPD.
Exactly.
Yes. Yeah, there is a lot of literature on prediction of BPD, and I think it's interesting data, but I personally think that it's kind of useless. Okay, the best predictor of BPD is gestational age and the severity of the respiratory failure. All of you neonatologists know right away when a baby is born at 23 weeks and he's requiring 50, 60% oxygen on a ventilator, you know that that baby has a very high risk of BPD. Yeah. And the best predictor is keep your statistics and compare that baby to your population. All these risk calculators, some of them are based on several units. The NIH obviously is the network, but again, the network is different from your experience in the United Arab Emirates, and it may be different from European units. Yeah. So I think that there is a value, but I don't think that for parent advising are very helpful. I don't think for research are very helpful. If you want to include a population that is at high risk, again, you just select the babies that are less mature and with more severe RDF at the beginning. So I think it's a nice exercise, and every year there are 2 or 3 papers with prediction of BPD. Yeah. I don't know what we do with that data.
So the hot question for you is this one, that why you are not using volume targeted ventilation?
Okay, I'm sorry I didn't have time during the presentation to explain that. And I have to say, we are doing volume targeted ventilation. Our therapists, our physicians are at the bedside, our nurses, and they are constantly looking what tidal volume is the baby getting. And if the tidal volume is too small, they will adjust the peak inspiratory pressure. If the tidal volume is too high, they will reduce the peak inspiratory pressure. So we are doing targeted ventilation, volume targeted ventilation. What we don't do is we don't give the responsibility to the ventilator to do that, because although it's very convenient for the staff, because you don't worry about it, because the ventilator will adjust the pressures automatically, we find, and we have used different ventilators. Actually, we helped Draeger develop volume targeted ventilation. So we were all vested on that technique because we feel it makes a lot of sense, because it wins quicker, it may prevent over distension and so on, but it's a very tricky technique. I always give the example, is the same thing as what happened with the Boeing 737 MAX. You are giving the responsibility to a volume sensor, to a flow sensor, okay? Same as if that volume sensor or flow sensor is given the right value, the ventilator will make the right adjustment. If that sensor gives the wrong value, the ventilator will do the wrong adjustments. And unfortunately, flow sensors in a ventilator circuit with secretions, surfactant, blood, humidity, very frequently fail. And the ventilators recognize crash, big failures, but small differences, the ventilator doesn't have any idea, and they just take the value that they are getting from there. So that's problem number 1, equipment. Problem number 2, what tidal volume do you use? 4, 5, 6. Each baby needs a different tidal volume at different stages of their evolution. Using a fixed tidal volume doesn't make any sense. And what happens is that if you use a tidal volume that is slightly below what the baby needs, the baby will struggle. The baby will essentially start breathing over because the ventilator is winning when it's not supposed to win. And the opposite is also true. If you are using a tidal volume that is excessive, what will happen? The baby will just quit. He will not breathe at all. And the ventilator will take over, something that we don't think is a good idea. So we use volume targeted ventilation for babies who are extremely unstable to stabilize their tidal volume, babies who have frequent hypoxemic episodes. But routinely for everybody, we don't think that is a technique that is sufficiently developed at this stage to recommend it routinely.
Okay. So
can I add something on that?
Sure.
I can only concur with Eduardo. I couldn't agree more. And on top of that, all the let's say the rumors on volume guarantee and this type of thing beyond the commercial pressure behind are also due to the fact that there are meta-analyses showing that sort of a volume control is beneficial, but they mix everything. They mix a volume guarantee from one type of machine with another volume guarantee using a different software with ventilators on volume targeted, which is again another techniques. So this is like, bananas and apple in the same meta-analysis, and it's not very. We only use volume guarantee during the very short time during the insure, you know, because you inject surfactant, compliance is gonna change pretty quickly. So for 10 or 15 minutes, we place them on volume guarantee just during the insure procedure, and that's it.
I have a question.
Yeah.
Go
ahead. Go ahead.
One question, Dr. Daniel. I am very interested in lung ultrasound, Dr. Daniel. I was going to use it for my new edition of the book. So the question is, what do you do for those who don't meet your lung ultrasound score? I'm very impressed with this lung ultrasound thing. It has to be a standard of care in all the units. Dr. Daniel.
So again, if you think about the lung ultrasound score at the birth, this is very easy. There is a very nice threshold from our studies, but also from others. There is a meta-analysis that has been published in archives 1.5 years ago, and another one we did for neonatology. So lung ultrasound score beyond 6 or 8 predicts the need for surfactant very, very accurately. Then there is the prediction of BPD later on. If you look at the lung with lung ultrasound serially, so let's say at day 7 or day 14, this is also, there are data about that. These are also very much significantly accurate to predict BPD. Then I can echo Eduardo again, because we are in a situation where, okay, we can predict BPD, beautiful. And with lung ultrasound, you can even see the lung, how it's doing, and you can, you know, see how it's doing every day or every week and so on. But unfortunately, we are in a situation where we can see that, but we don't have any weapon for the BPD. Okay, you see it's not doing well. What are you gonna do? What is the drug you're gonna give to the baby? There is actually no perfect drug for that. So ideally, especially now we have something that is repeatable, non-invasive, and easy to use a lung ultrasound, I would say that if we're gonna have a beautiful drug for BPD, doesn't matter if IGF-1 or any other, I don't know, hopefully one day we're gonna have it, you can maybe select population also using a lung ultrasound. Otherwise, the usefulness for BPD or lung ultrasound explicitly resides in the titration of mechanical ventilation. This is something very useful, because if you want to do your alveolar recruitment, it doesn't matter if it's non-invasive or in volume guarantee or in high frequency or whatever, you can see the effect of your alveolar recruitment at bedside in a few seconds with lung ultrasound. And this is why we do that while using the aggressive non-invasive protocol that I showed you. There are other techniques to visualize the effect of the alveolar recruitment, but unfortunately they are not point of care, they're not at the bedside, and especially thinking about electrical impedance tomography, it's not marketed and it's much more difficult and blah, blah, blah. So.
Because Daniel, I wanted to ask you, this lung ultrasound should be a standard of care in the bedside when you're optimizing lung volume. And the genesis of BPD lies in the optimizing lung volume at all points in time. So lung ultrasound and artificial intelligence, they'll be able to fine tune this every hour or every half an hour.
I think we are mixing two things. BPD is not lung volume. BPD is much more complex than that. Surely in babies that are evolving towards BPD, we can see that is a worse lung aeration, that's for sure. But the discriminatory power of lung ultrasound, let's say the precision of visualization of lung ultrasound does not go in such details to allow you to see alveolarization, okay? You only see the loss of lung aeration. This is what you see. It may be, it is actually associated with the development of BPD. We published that in the Blue Journal, but it's much more useful and sensitive in the acute phase of respiratory failure. And it doesn't matter if it's RDS or ARDS or meconium aspiration or pneumonia or whatever. Then it's very much useful, because all these acute respiratory failures are basically loss of lung volume, while BPD is also arrested alveolarization and so on. So when you say it should be standard of care, I totally agree. I couldn't agree more. And I can tell you that in this regard, neonatology is very much delayed, because if you look at the literature in adult critical care, it is standard of care in adult critical care. The first guidelines, evidence-based for the use of lung ultrasound in adult ICU dates back of more than like 15 years ago. We proposed the first one last year. So there is a delay over at least 10 years, more or less.
Very good. I'm very impressed with the technology.
Okay. I have a couple of more questions for Dr. Ben-Clary before he goes. Dr. Ben-Clary, the early versus late caffeine, what do you think about that and the use of caffeine in the delivery room?
Okay, I'm glad that the question came up. And I could talk about this for a couple of hours, but I will try to answer in a couple of minutes.
Okay.
Caffeine is a great drug to treat apnea and to extubate patients. It has never been shown that it's a drug that prevents BPD. Never. There is no paper in the literature. The paper that triggered all this was the CAP trial that Dr. Barbara Schmidt initiated to see if caffeine was safe. Her concern was caffeine was doing a lot of brain damage because there is a huge amount of animal literature showing that caffeine in high doses and in certain circumstances can produce brain damage. So the CAP trial was great. It showed that caffeine does not produce, I don't think that it showed that protects the brain, but it clearly showed that it doesn't increase the risk. That study did not have BPD as one of the main endpoints. In fact, the population that was included in that trial was babies that were going to be extubated within the first 10 days. Who is going to do a study to evaluate BPD and include that population? So that's number one. Number two, that trial, the control group, was a under control group because those babies did not get caffeine for apnea or for extubation. That was an indication that had been already proven to be effective. So you are comparing caffeine with absence of caffeine, complete absence of caffeine. And that's clearly not what I'm proposing. Caffeine should be used for extubation and for apnea because there is clear evidence for that. Now, there were several retrospective analyses, including the CAP trial, showing that babies who got caffeine early did better than late. So everybody, all the neonatologists in the world now are saying, so we have to start caffeine, giving coffee to the mother, and then a dose immediately after the baby is born. There is absolutely no evidence from good prospective randomized trials showing that early caffeine in babies who are ventilated makes any difference. In fact, the results I showed, that is the largest retrospective trial from the pediatrics group here in the US, didn't show any effect. The only prospective randomized trial is a pilot study that we started, only 80 patients, because the OSMB, the review panel, told us to stop the trial because there was increased mortality in the babies who were getting early caffeine during the first 3 days. Two small numbers, that's why I didn't even mention it. I don't want to implicate that caffeine will increase mortality, but certainly in our study, there was no benefit at all in babies who get caffeine the first 3 days from those who get caffeine at the time of extubation and for apnea of prematurity that are the classic indications. So our feeling in our unit is that there is absolutely no reason to start a drug that can have serious side effects. And you can see some publications from the group in Harvard showing increased cerebellar hemorrhage with high doses of caffeine and alterations also in tone at 2 days of age, at 2 years of age in these patients. So caffeine is not a benign drug. It's not water. It has effects on practically every cell, and at high doses can produce significant side effects. So our position on that is we do where we know that there is pretty good evidence that helps. We don't think that there is evidence, again, to use it to prevent BPD from the first day of life.
Okay. Last question from my side. The surfactant use. If the baby cannot be intubated and develop the BPD or the late surfactant use, it might help, or is any study about that?
Yes, Roberta Ballard was the PI in a study to evaluate the effect of surfactant with nitric oxide combined in babies who were stuck on a ventilator to try to see if that would improve lung function and help reducing BPD. The results were not clear, and certainly they did not confirm their hypothesis that this could help. And unfortunately, again, the intervention was combined with nitric oxide. That is something that I don't think is justified either, to give nitric oxide for long periods of time to all these babies.
Then
Okay,
one question to Dr.
yes.
Vineet. Dr. Vineet, one question to you. How you have already answered this. When do we start vitamin E? At what age? You already classified, Dr. Vineet. You told the vitamin A within the first.
So when we used to use it in one of my previous this thing, I don't use it in the unit right now because, like I said, we just don't see it being beneficial because our population we think has adequate amount of vitamin A levels. But when we were doing it based on Dr. Tyson's study in NEJM way back in the 1980s, I believe it was published. So that was starting at birth for the first 3 times a week for the first 4 weeks and using 5,000 international units. So that was the dosing that we had done, yeah.
Can I say something about vitamin A?
Yeah, sure, Dr. Go ahead.
Again, vitamin A is one of the few drugs where there is evidence, more than one randomized trial, prospective randomized trial, well conducted. And the thing is that we are not giving vitamin A as a drug that will improve alveolarization or decrease inflammation. We are giving vitamin A to prevent deficiency that is known to occur in babies that are not getting sufficient vitamin A. So the reason, again, to use it is in babies who are not feeding, who are getting only parenteral nutrition, where the vitamin A that we add is inactivated by light and adheres to the plastic. So the amount of vitamin A that these babies are getting while they are not feeding is insufficient. And there is lots of data showing that the vitamin A levels can be normal at birth, but with time, over weeks, if the baby doesn't get additional vitamin A, they get vitamin A deficient. And that is one of the factors that has been shown to impair alveolarization. So the idea of vitamin A, again, is to prevent the development of A deficiency. If you are able to measure in your lab, I think that that's great because then you can initiate the therapy with a known low level. If you cannot measure vitamin A, again, the data from all the studies showed that the vitamin A levels drop if you are not giving additional vitamin A. Now, there is a question, I think, also there, whether you can give it orally. And yes, Dr. Chennai and in Vanderbilt, he showed that using vitamin A orally is also absorbed. Not as well, obviously, as the parenteral product, but it can be absorbed to a certain level and maintain vitamin A levels better. So it is an alternative.
Okay. So other panelists have other questions to Dr. Mankalavi?
1 minute for Vineet, one question. Vineet, I wanted to ask you regarding this vitamin A we answered. Then do you treat all ureaplasma infections is one question to you.
Yeah, so we don't routinely detect ureaplasma because part of the reason it's not that easy to detect and, unless you have PCRs. So we did try to do a study earlier on where we tried to detect, and as you know, ureaplasma only comes from the mother, so you can't get it from the sink or from your environment. And if you look at the data, and again, the group in University of Maryland had done some very nice work. They've been sitting on the edge. So they've tried azithromycin, they've tried so many different approaches, but the data is not strong enough for at least us to routinely screen and then treat, because we're not really sure that even if you treat it, if it makes a difference or not. The way I look at ureaplasma is that if you are a preterm baby and you're sitting on the edge of getting BPD or not getting BPD, and you get an inflammation secondary to ureaplasma, which is a low-grade inflammation, that might tip you towards getting the baby getting BPD. So it is at that point, we look at babies less than 28 weeks that I worry about it. I will tell you, my maximum effort in these babies is, first of all, get rid of the tube. That is like my major focus. Get rid of the tube, keep the oxygen under control, provide good nutrition, and then hopefully that'll be fine. I don't know many places that routinely do uroplasma, checking if the baby is intubated and then treat if it's positive. I can tell you that if you, and I have been stoned by the studies done by the University of Maryland group, if you treat all babies by erythromycin, that trial did not show a benefit in decreasing BPD. So treating all babies and with or without, I mean, you test it, but you don't get the results quickly enough, and they treat it, and that has not been shown to decrease BPD.
Okay.
So I
Yes.
think we've answered most of the questions today. I think we've answered.
Yeah, I think we whatever I have the list of question, mine and the participant which sent it to me, we gave it already. So
Dr. Vidyasagar has some questions.
Yeah, Dr. Bandari.
Dr. Vidyasagar has some question.
Yes. Okay, go ahead.
Just a question to Eduardo. What does the crystal ball tell us in 2030? Will you be discussing a BPD still?
Unfortunately,
yes.
I think so, because again, as I mentioned before, the original BPD was preventable because it was a sort of iatrogenia. We were inducing it. The present BPD is a problem of development that doesn't only affect to the lung, but there is every day more and more evidence that all the organs in an extremely low birth weight infant are not developing the way they are supposed to develop. And there is a paper published just a few days ago, or weeks ago, showing that these kids, when they reach early adult age, have much higher mortality. And mortality not only because of lung disease, but because of cardiovascular issues and a number of other problems. So I think that as long as we have extreme preterm infants being born and surviving, unfortunately, I think that probably we'll be seeing and realizing a increased number of sequelae rather than reduction. So the only reason why my answer would be no is if our colleagues in obstetrics develop a strategy to eliminate preterm births, and in that case, all neonatologists will be obsolete and we will not have to worry about anything because most of our practice is around the extreme premature infant. Those are the kids who have issues.
Yeah, we had a lot of hopes with the surfactant thinking we'll cut down the BPD. It did not happen. We thought of antenatal steroids. It's not happened. So I think we are reaching a limit of our expertise or science to have a preterm baby well-developed lungs. So
actually the two examples that you mentioned are excellent because antenatal steroids and surfactant are probably the most effective drugs in neonatology in the last 40 years. They have improved survival dramatically, but all the complications associated with extreme premature infants have increased because of that, because we have a larger population that is susceptible to these complications. So I think that the only answer really is prevent prematurity or have a artificial placenta and uterus that is so fantastic that imitates what happens in utero and allows these babies then to develop into full term normally. And I think that that is I don't know, I don't think will be in 2030. That will take a long time.
One last question.
Raji will continue 2:30.
No, I won't. This last question to Vineet. What is the BPD rate in your unit?
So our chronic lung disease, using the Vaughan definition, we have BBs less than 1,500. We are on the high side right now in the new unit that I am in right now. So here we have somewhere between 35 to 40%. So it's on the high side and I have to work on, we don't have the proper tools to get it down. But I can tell you, for example, when I was at Yale, when I came there, we had a BPD rate around 40%, and then we targeted non-invasive ventilation, decreased infections, and targeted the oxygen saturation. And by the time I left there in 2015, we had gone down to 19%. So right now I'm working, because this is a new unit and I've only been here for a year, I'll need some time to try to get this thing turned around. Yeah, but it's high right now in my unit right now at Cooper.
today I thank you for a beautiful session, and we have answered all the questions. We have lived up to the expectation of all the people. A good response have come in. So I would ask Dr. Jayasheela to say a vote of thanks to the excellent CME we had today. It was so educative, informative, illustrative, and interactive. In all the 4 areas, we have scored 100%, which is very unusual. So I call upon Jayasheela to give the vote of thanks.
I would like to thank Dr. Rajiv for bringing such great people to us and helping us and enlightening us towards care of these little babies. And like we all know Dr. Vidyasagar since our undergraduate days from Downey's Core, and like to see all together in this CME is such a big thing for many of us, youngsters like us. And thank you all for helping us in the journey towards caring, taking care of these little babies and helping us to improve their survival. And by survival, we just wish that these strategies will help us to give them an intact survival. That's it. And thank you so much, all of you.
Thank you very much, all of you. A great CME we had. It will be historical, Dr. Sagar, like 25 years back. This will be a historical CME to be compared off and on. Thank you so much.
Thank you, thank you, thank you.
Thank you. Bye-bye.
Thank you very much and congratulations.
Bye, Eduardo. Bye, Rajiv.
Thank you.
Bye-bye, everybody.
Bye-bye. Great seeing you.
Keep safe.
Yeah. A word to the audience. So this program was accredited with 4.5 CME points from UAE Ministry of Health. So the certificate will be delivered to your email within 1 week, inshallah. Okay.
Thank you, Tawfiq, for arranging everything.
Thank you, Tawfiq, for arranging such a fantastic time-bound CME. You have almost become a doctor. In fact, all the doctors asked, "Are you a doctor?" So we will give you a certificate as a doctor with 100 CME points.
Rajiv, it looks like there were maximum number of attendees were at one time 589. Maybe perhaps you can distribute them by region later on and send us information. It will be very interesting.
The attendees were around 1,000. There were 1,000 attendees.
No, and when I was looking at the participants here, they were showing 500. Maybe they did not register properly.
No, we saw 1,000 today.
Okay, good, very good.
1,000 people. So I thank everybody, Dr. Patrick, Dr. Vidyasagar, Dr. Eduardo, and Dr. Daniel, and Dr. Vineet for such an excellent CME, which will be a landmark CME, which can be compared in the next few years, I think. Thank you all. Good day. Good night. Thank you.
Thank you. Thank you.
Right.
Good night.
Thank you, Tawfiq.
Night.